It's a pleasure to be here, PK. As always, congratulations. We're going to talk about bioabsorbable scaffolds for the next few minutes, and I think we've already demonstrated in this case the need for a scaffold. You heard from Nick very elegantly about dissection. Here's a case from a few years ago. It's a TP trunk occlusion. We crossed, and luckily we were able to save both branches, and we ballooned it. We thought the balloon angioplasty result looked great angiographically until we did an OCT run. And then, as is typically the case, it looks like a bomb went off inside the artery. And there's multiple dissections, which are unlikely to stay open for very long without some sort of scaffolding, no matter what kind of prolonged inflations you do. You heard from Nick that the meta-analyses support the use of drug-eluting stents over other technologies. However, permanent scaffolds have their limitations, and particularly with drug-eluting stents, all the studies look at relatively short lesions, whereas with DCBs, we use long segment treatment, but then we don't have any available technologies. So there remains a need for a technology that will both inhibit intimal hyperplasia, scaffold those kinds of dissections like I showed, and also leave nothing behind. And so the ideal treatment, which checks all the boxes, if you will have all of those properties. So one can imagine what that might be, but certainly this is the driving ethos behind developing the so-called drug-eluting resorbable scaffolds. And the idea is to have a appropriate intimal hyperplasia treatment with a drug, minimize recoil and repair dissections, and then ultimately leave nothing behind. And so angioplasty was the surrogate for this, but the scaffolding part is what we couldn't get. And so we've had in clinical and investigative paradigms a variety of different bioresorbable scaffolds for now over a decade. The first generation Absorb BVS device developed by Abbott was a PLLA scaffold that was semi-crystalline, and it provided both structure and radial strength that was comparable to coronary drug-eluting stents and did fully resorb, as you can see from left to right, over the course of approximately 3 years. So you can see in the panel at 12 months, you can see that the square outline of where the bioresorbable scaffold strut might be embedded into the vessel. At 2 years, it's starting to involute. And at 3 years, it's really replaced by a collagenous matrix, such that by 48 months, it's essentially gone entirely. And even on optical coherent tomography imaging, it's hard to identify. So with this technology in mind, Ramon Varco in Australia undertook upon himself a series of patients that he then followed for the next 5 years. All of these patients had below knee disease, and the overwhelming majority were CLI patients. Rutherford's 4 to 6, and he, in a non-randomized fashion, enrolled patients with multiple or single disease greater than 60% in the infrapopliteal segment with lesion lengths less than 5 centimeters, so relatively short lesions with reference vessel diameters of 2.5 to 4. And he followed these patients for an astonishing 5 years. In his initial study, you can see where on the right-hand side, he treated 55 limbs with 71 scaffolds implanted all the way down to the distal third of the ankle in all of the different tibial vessels. And he showed that there was substantial improvement both clinically in terms of Rutherford-Becker classification, as well as in terms of primary patency. So these are sort of remarkable data. You can see that over the time of the experiment of 5 years, he identified primary patency in approximately 72% of patients using a Kaplan-Meier technique, and also freedom from clinically driven TLR of an astonishing almost 91%. And so subsequently, in collaboration with Atman Shah in Chicago and Steve Coombe in Singapore, these 3 investigators pooled all of their data, and what they showed, excuse me, in 125 total patients with 156 lesions, with a mean lesion length of approximately 2.5 centimeters, with a mean diameter of 3.2 millimeters, that they achieved 1-year primary patency of 91%, and 2-year primary patencies of almost the same, 88.6%. And their freedom from clinically driven TLR, I think, frankly, for a below knee study, was breathtaking at 94.5%. So this is with the first generation absorb device, which for a host of reasons is no longer clinically available for coronary intervention. But for the below knee segment, it seemed promising because there was 100% technical success and really, really high primary patency and very, very good limb salvage. So along with this technology, there's now a host of other technologies, and I'm not going to discuss any of these others today, but there's certainly the Biotronic Magmaris, the Merrill MiRes, which is also a PLLA scaffold with sirolimus, the Riva Motive device, which also has sirolimus, and Ephemeral is developing a bioresorbable with both sirolimus and paclitaxel, and they're now also in human. So there's a host of drug-eluting resorbable scaffolds. It's been rebadged and rebranded for those of you that remember Absorb and called it BRS, largely to emphasize for those that are uninitiated that it's a drug-eluting technology. So with these preliminary data in hand and with all the competition in the space, Abbott has undertaken the Life BTK randomized trial. I'm privileged to be one of the global co-PIs with Ramon Varco, who really pioneered this space, and Brian DeRobertis, who's now also relocated here to New York. And so in this study of 225 patients, there'll be a 2-to-1 randomization of Esprit BTK, which is the new generation bioresorbable scaffold, versus balloon angioplasty, which we consider the standard of care. The primary endpoint is a 6 months composite of major adverse limb events plus perioperative death. And obviously the efficacy endpoint is a composite of primary patency coupled with limb salvage. There will be core laboratory adjudication of everything from angiography and ultrasound to wound healing. And there will be a longitudinal follow-up of 5 years. We here in New York are gifted with multiple investigators. I see several in this room. And we have really had very strong enrollment despite beginning a trial in the midst of a pandemic. We're over half enrolled as of this week. And we're looking forward to hopefully accelerating and completing the trial early next year. And again, the predominant group of patients are Rutherford 4-5. It's going to be in the proximal 2/3 of the infrapopliteal arteries with a maximum of 2 lesions over a lesion length less than 170 millimeters with reference vessel diameters of 2.5 to 4. The next gen bioresorbable scaffold that we're using is the Esprit BTK. In contradistinction to the prior generation, it's much thinner. It's 99 micron strut thickness, not that different from the current metallic drug-eluting stents we use. And it'll be using everolimus at a density of 100 mics per square centimeter with a polymeric design, again, very similar to the Xience underlying corrugated ring platform that is really now the standard of care in coronary drug-eluting stents. And so in sum, I would say that although we've had some success with drug-eluting therapies above the knee, we really have not been successful outside of coronary DES in the below knee segment. The ideal tibial treatment we would hope would be both a drug-eluting technology, which is a scaffold that can prevent recoil and will leave future options, including surgical options, for those high-risk patients. The early feasibility studies with the first generation Absorb have demonstrated excellent primary patency and long-term freedom from clinically driven TLR. And obviously, we're super excited about the Life BTK study, which is now well underway and is because of these operators hopefully going to be a big success. Thanks very much.